So why don't we get started then? Yeah? Okay, you guys, thank you for having me. So you know that you have your formerly Gnosis, now Relias training coming up. Remember that? That thing that you guys love to do where you get to go in and answer all of those odd multiple choice questions that have expert answers. One of the goals that your nursing admin has for you is, no, the light's fine. One of the goals your nursing admin has for you is to improve everybody's medical knowledge, meaning as a unit, we're looking for everybody's scores in the realm of medical knowledge to go up. This is a challenge when we have a lot of you already do really well in terms of your medical knowledge and scoring on this test. So we're going to do a series of 3 lectures, this one on NICHD fetal heart rate terminology. We'll do one on obstetric hemorrhage and one on vacuum delivery. Is trying to boost up everybody's medical knowledge. So I'm going to go over some definitions today, hopefully some stuff that's going to help sink in these definitions, as well as what we do with fetal heart rate tracings in response to abnormal tracings. I will also go over why we respond to abnormal tracing and show you a very complicated diagram made by Dr. Perer. That fortunately you guys don't have to memorize, but hopefully I'll get that to sink in a little bit. And we'll do this all in the context of a case. The other thing I want to say here is that even though I know you all know the NICHD terminology, and this might be a little bit of review, one of the very big key things here is the importance of actually using this terminology when we communicate about fetal heart rate tracings. So to get called, and you guys know I work as an attending here on labor and delivery, when I get called and I get told I have a funky tracing or I have bad or good, it really tells me absolutely nothing about the condition of either mother or baby. When we stick to our definitions, that's when we start to improve communication and prevent error and prevent harm. So I would encourage you after this session, and always, whenever you communicate, you want to use the terminology set forth by the NICHD. So this is just going to be a little bit on a case. So this is a patient, she's 40 and 3/7 weeks, who comes in for ruptured membranes. She's had contractions for 2 hours. She had prenatal care in Mexico. Her father accompanies her, and by the way, he's an obstetrician in Mexico and has been providing her care there, but then she walks in here. She has no other medical problems, has previously had an appendectomy, has a blood pressure that's 130/86, and is contracting every 1 to 2 minutes. Her cervix is 3 centimeters, 100% effaced, -1 station, and she has grossly ruptured clear fluid. It's a pretty common scenario, right? Pretty low risk patient. So she's admitted for early labor with ruptured membranes, GBS unknown. Started on penicillin for GBS prophylaxis. And this is her tracing, and I know it's a little bit short, but this is her tracing at admission. So does anybody want to comment on what's the fetal heart rate baseline here? There's muttering in the room. 140, 145. How do we define baseline? Okay, so this is where we should have really quick answers, everybody. So fetal heart rate baseline is defined over a 2-minute stretch of relatively consistent heart rate. It's the average heart rate, and it's rounded to 0 or 5. So you never say a fetal heart rate baseline is 143. Okay, that's a single point. It's 140, 145. You can round up, and it's an estimate over the most continuous flat portion of that tracing. It's 2 minutes on average. And those 2 minutes that you take to determine fetal heart rate do not need to be continuous. So you can have a 1-minute stretch and a 1-minute stretch. So you're looking for the relatively flat parts over about a 2-minute stretch. So probably around 145 here. She gets an epidural, and this is her fetal heart rate tracing following that. And we can see 145, 140 maybe for baseline. Are there accelerations? What's the definition of an acceleration? I'm hearing 15s. Okay, 15s, easy to remember, right? There is a 15 beat rise above baseline in the fetal heart rate lasting at least 15 seconds long. What does the presence of an acceleration tell you about the baby? We're not acidemic, okay? So it doesn't really tell us if the baby is getting oxygen okay. It tells us that we're not acidotic. Once we have acid in our bloodstream, we no longer can produce those physiologic up and downs in our heart rate, and that's because we're compensating for that acidosis, okay? So oftentimes you'll see an equivocal pattern where we're watching a category 2 tracing and we're not seeing acceleration. We'll go and perform fetal scalp stimulation. What we're looking for in response to fetal scalp stimulation is that acceleration, like you see here, a 15 by 15 point rise. That tells us baby's not acidemic. If it's not present, does it tell you anything? No. Okay, so there is absence of accelerations does not mean acidemia. Okay, but at least at this point in this fetal heart rate tracing, because of that presence of an acceleration, we can say there is not acidemia. Following an epidural, what kind of decelerations do you see here? I'm hearing lots of variables. Okay, so what's the definition of a variable fetal heart rate deceleration? Everybody's saying words and they're all different. So a fetal heart rate deceleration, variable deceleration, is at least a 15-point decrease below the baseline. It's a sharp decrease, meaning that that step off comes right down in a less than 15 second time frame. So sharp. Often V-shaped, although they don't have to be V-shaped, but whenever you see that V for variable, right? And occurring with a timing that's not relative to contractions, meaning they can occur with contractions, after contractions, or in between. They're variable in their timing in relation to the contraction. So I'm going to go over those definitions again. I'm going to throw them up on the screen. This does look like a V. It is a 15-point decrease below our baseline of 145. It is a sharp drop-off, so you can call that a variable. This, however, doesn't have a sharp drop-off, right? It has a gradual decline to a nadir, or the lowest part. Nadir means lowest part of that fetal heart rate deceleration, that occurs after the peak of the contraction. So that isn't a variable, right? Didn't meet those definitions. So what is this? Late. Good. So this is this whole case of this heart rate pattern that I'm pulling out little snippets to show you. There's a lot going on. You can see here the baseline a little bit more clearly. Can you comment here on what you think the variability looks like? What are our 3 types of fetal heart rate variability? Good. Minimal, moderate, marked. Minimal variability is a beat-to-beat change that is 0 to 5 seconds or less, right? Moderate variability is a beat-to-beat change of 5 to 25, and marked variability shows marked variation of more than 25 beats in amplitude. Okay, so you know those definitions, but nobody answered. What is the variability here? It's hard to see because it's little. Yeah. Does it look like it has the normal wiggle in it to you, right? So you guys don't even really need to think about those definitions so much. I mean, when you're taking your course, you need to know those numbers. But it looks like it's minimal variability overall. Okay, good. And then here's that little section I pulled out for you earlier with that variable but now late. Look what happens. And what are these? Lates, right? Okay. And they're deeper and they're worse, right? So when you see a pattern like this and we start to see some lates developing, and the fetal heart rate tracing I pulled up right before this course had that in it, that one that's on our floor right now, it's a very, very big warning sign, okay? So category 2 fetal heart rate tracings, if we leave them alone and don't intervene, this is what they do. They get worse. So what do we do if we have a category 2 fetal heart rate tracing? Something, right? We do intrauterine resuscitation, and the biggest thing is we notify everybody, and we get an operating room ready in case we need it. Okay, so in this case, in response to that big sequence that I just showed you, and a fetal scalp electrode was placed, as well as an internal pressure catheter. And we see kind of more of the same, okay? There's lots of decelerations in here. Can you guys comment on the variability from this overall pattern? Does it look like it's minimal, marked, moderate? Okay, good. So overall, I think if we just glance at this, right, your overall impression, you see quite a bit of wiggle, and you say moderate. No. And the reason is you cannot look at variability during a deceleration to determine what the baseline variability is, okay? So remember when I said the definition of baseline fetal heart rate is that 2-minute stretch, it's in between. You also, for defining variability, need to look in those same sequences where you're determining the fetal heart rate baseline. Is that wiggle there in those stretches that are relatively constant? You cannot measure variability during a deceleration. Question from the floor.
When they say like, oh, there's a decel, but there's variability in the decel.
Okay, so the question is, there's a decel and there's variability in the deceleration. Does that have any meaning? And the answer is no. It is simply a deceleration. Decelerations fit into 3 categories: early, late, and variable. You look at those decelerations, you determine what kind of fetal heart rate decelerations they are, and you determine the variability from those periods when we are not in a deceleration, okay? And the variability that's going to tell you the baby's not hypoxic is not the one during a deceleration. And if we think this through, if you think about what's happening in the fetus, so if we're having a fetal heart rate deceleration, we're not perfusing as well. We're not transporting oxygen around our body as well, right? So it's that time that the baby's stressed, and that's what causes the acidemia to develop. So if we are trying to recover, if we are trying because we have built-in baroreceptors, chemoreceptors that respond to that lack of oxygen, trying to get our heart rate back up, right? Like our bodies are designed to survive. That's not okay. That's a stressful event. So the variability that's happening there, that's not good. That's in response to a fetal heart rate that's low. The variability that's in between, when we have a normal fetal heart rate, that's signaling that our parasympathetic and sympathetic nervous systems, which work in coordination with each other, are balanced. We're not having a physiologic response to stress. We're working the way we're supposed to. We're not trying to survive in between. We're surviving, right? We're thriving. During a decel, we're just trying to survive. All right. So unfortunately, this tracing doesn't get a lot better, and there's a lot of recurrent late decelerations, and really, unfortunately, almost no intervention to try and get this tracing to improve. And this is, again, to show you some of these are variables. They have an abrupt decrease. Some are late. But if we don't pay attention to, recognize, and respond, the natural course is to have a really bad tracing, okay? This patient was progressing very quickly. She was complete. There was an attempt at a vacuum delivery. There was 3 other deliveries occurring at the same time as this one on this unit. Unfortunately, baby didn't do very well. So again, variable deceleration, quick V shape, okay? Yes, it's after a contraction, but it still meets criteria for a variable deceleration, not a late deceleration. So you can say it's a variable deceleration. The nadir occurred following a contraction. That's okay, but late decelerations have a smooth shape. This is a late deceleration, smooth shape following contraction. Okay, so to reiterate, an early deceleration, we haven't gone over that definition. You guys can read it for me. Good. Okay, everybody should read that aloud. Read it over and over. One of the ways we learn and remember is through repetition. An early deceleration is a gradual decrease in fetal heart rate with the onset of the deceleration to nadir over 30 seconds. The nadir occurs with the peak of the contraction. And these, I think everybody has a really easy time seeing. They look like a flipped contraction, right? Okay, great. A variable, I know I'm harping on this, but a variable looks like a V, sharp decrease, abrupt decrease in fetal heart rate of 15 beats per minute. If the deceleration is less than 15 beats per different drop from baseline to nadir, it is not a variable. There is no terminology for that. I don't know what to tell you to call them, but don't worry about them. They don't matter, right? You have to have a 15-point drop in the deceleration to have it affect fetal health. The onset of the deceleration to nadir is less than 30 seconds, and the deceleration has to last more than 15 seconds to be called, and under 2 minutes. A shoulder, if present, is not included as part of the deceleration. And shoulders are when you see these accelerations on either side. They do not count in the time of the deceleration. And then a late deceleration, a gradual decrease in fetal heart rate with onset of deceleration to nadir over 30 seconds. The onset of the deceleration occurs after the beginning of the contraction, and the nadir of the contraction occurs after the peak of the contraction. Okay, so this gets really easy now, right? Because we get 3 categories, 1, 2, and 3. 1's really easy, right? It's normal. It's what you guys are used to looking at. It's what you see all the time. The baseline heart rate is normal, which is defined as between 110 and 160 beats per minute. The variability is moderate. Accelerations, they can be present or absent. If you see accelerations, it's almost always reassuring, right? But it doesn't mean it's a category 1 tracing. So we use accelerations, but not necessarily always to categorize it 1, 2, or 3, okay? Later variable decelerations are absent, and early decelerations, they can be present. You can have a category 1 heart rate with decelerations, only if they're early, okay? Category 3, it's our other easy category. Category 3 is bad. The baby's dying. It's ominous. Consists of absent baseline variability. And the reason that's so important is it turns out that the fetal heart rate variability correlates the best to the degree of acidosis in the fetal placenta unit. Absent baseline fetal heart rate variability plus, okay, there has to be more. Recurrent lates, recurrent variables, bradycardia, or a sinusoidal pattern, which is a very unique pattern. If you guys can find one, I really want to see a sinusoidal pattern. I've never seen one. They occur when a fetus is anemic, typically with RH or anti-D isoimmunization. And they occurred a lot more often before we had ROGAM. So we don't see people really sensitized these days and having a lot of fetal anemia. But they come up on your ROLOFF testing. Sinusoidal patterns just look like a wiggle up and down. If there is an acceleration in the middle of it, that is not a sinusoidal pattern, okay? So if you're anemic and your fetal heart rate's going up and down in a sinusoidal pattern, the anemia doesn't go away all of a sudden so that you get an acceleration. So they like to test on this. If you see an acceleration in the middle of a sinusoidal pattern, it's almost always considered a pseudo-sinusoidal pattern, in which case we think of narcotic administration causing that.
I have a question.
Sure, question.
People with sickle cell moms, can they have sinusoidal?
Do fetuses born to mothers with sickle cell disease have sinusoidal patterns? No, because the fetus is not anemic. Okay? Okay, so if we have an abnormal heart rate pattern, we're gonna do some stuff, right? So this is a decision tree analysis. This is put out by David Miller. What do you do? So you confirm the fetal heart rate and uterine activity, and if we have a category 1 tracing and the patient is low risk, we do routine surveillance, right? Every 30 minutes in the first stage of labor, we'll review the tracing, and every 15 minutes in the second stage of labor. If we're a category 2 or 3 heart rate, though, we got some extra work to do. We're going to go on alert. And I like Dr. Miller's algorithms because he uses ABCDs, which are really easy to remember. So A is we're going to assess the oxygen pathway. Where does the oxygen pathway start? It starts with mom and her breathing, okay? So the A's in a abnormal fetal heart rate, any abnormal, category 2 or 3, you want to check maternal vital signs and oxygenation, okay? B, you're going to begin corrective measures, intrauterine resuscitation. And the type of corrective measures you're going to do are going to depend a little bit on the scenario, the patient's risk factors, all the stuff that's kind of happening and what that tracing looks like. And then you're going to assess for the presence of moderate variability or accelerations, because remember, those two things are going to tell us that we're at low risk for acidemia. And we're going to look for the absence of clinically significant decelerations. And I'm going to go through what that means in just a moment. If we can't reassure ourselves that things are okay and we're okay to continue this labor, then we're going to move to C, clear obstacles to rapid delivery. So if that means the patient's complete and +1, we're going to get ready to perform a vacuum delivery, right? If she's 3 centimeters, we're going to get the operating room ready, but we're going to clear that pathway, make sure that we have all of those things and tools we need to safely deliver expediently. And D, we're going to determine how much time do we actually have. So this is, again, going to be dependent on the tracing. If you think back to the case I just showed you with those big, huge lates, how much time do you have? Like 0 minutes, right? But before, when we had variables and lates in that tracing, did we have some time? Did we have a decision to delivery interval? Yeah, I mean, I think in that case, because it got worse, we waited too long. But we can sort of guesstimate, we have 10 minutes in this case, or we have no minutes. I need everybody on board.
Let me just say one thing.
Yep.
So about C and D, that starts actually when you guys come into your rooms. Don't wait until the patient gets in trouble to start clearing a pathway. When you guys come in these rooms, check your cords, check your plugs, look for all the stuff that's in the rooms. The families cannot have all this stuff all over the floor. That's why we have counters, closets, sinks. Make sure that your room, and that's from the start, because you do not want to wait until the patient and the baby are in trouble to start trying to clear a pathway. That should be in the beginning when you guys come on your shift with every patient.
So Andrea's point is well said. The C, clear the pathway. There's a lot of stuff you guys do there as nurses. Lines being tangled, being able to unplug and move to the OR quickly if we need to. Even if we're setting up for a vacuum delivery, guys, you still need to make sure that we can get to the OR quickly, because remember, not every vacuum works. Some fail, and we have to go very quickly in those cases. This ABCD thing, this whole thing, is in seconds. The same as in a code. You guys do ACLS still? Airway, breathing, circulation, right? So it's really in rapid sequence. Here for you guys, when you're doing intrauterine resuscitation, it's assess oxygen, begin corrective measures, clear the pathway, and determine how long you have, okay? Get everybody there if you need them quickly. And then in this pathway, is vaginal delivery likely before the onset of metabolic acidemia and potential injury? Now, I think this is a question for the physicians, not for the nurses. This is where we need to come in and evaluate. We need your help clearing those obstacles. And then we need to come in and really decide how much time we have and if we think we can safely proceed with operative delivery or not. If we can't, then we need to expedite the delivery surgically or operatively. And if we think that vaginal delivery is likely before the onset of acidemia, then we can increase and heighten our surveillance monitor because we are never sure if we're right, and we could have more rapid deterioration than we were expecting. Okay, I know this is a little intimidating, but this is actually really useful. And Dr. Pear, unfortunately, he passed away a few years ago, really worked very hard on this color scheme. And we're very glad this didn't roll out to you guys, because in terms of testing, it would be impossible. But I think it's important to sort of understand. And there's a lot of really good and sound research behind these color categories. So as you would think, green and blue mean okay, right? So green and blue here, the colors, the risk of acidemia and the risk of anything evolving into something problematic for the fetus is very, very low. Yellow means we have a moderate risk of problems and we need to increase surveillance. Orange and red mean we have something going on, we need a high level of surveillance, or red, really we have an unacceptably high risk of acidemia and we need to deliver expeditiously. Okay, so there's not a ton of blue and green here, okay? So blue and green, the only time we can have really green is if we have a normal fetal heart rate tracing with no decelerations. Early decelerations are okay, remember that's still category 1. Or we can have mild recurrent variables. And I like the definition of recurrent variables that Pear uses, because we don't see with mild variables any change in the acid-base status of the fetus. We actually only start to see it when we see moderate to severe variables. And we define moderate variables as lasting 30 to 60 seconds and reaching a nadir of 70 beats per minute, or lasting over 60 seconds and touching down to 80 beats per minute. The reason that's, it's physiologic. So the slower your heart rate, the more oxygen deprivation you have, the more the acidemia, right? So the depth and length of the variable matters. And what it turns out is that moderate to severe variables cause more fetal injury than lates. The thing we're all scared of and react to really well are lates, and we don't do as good reacting, and this is not just you guys as a unit, this is in the country, we do not do as good a job of reacting to moderate and severe recurrent variables. Severe recurrent variables last 1 to 2 minutes, touch down to 70 beats per minute, or last over 2 minutes, that would be a prolonged deceleration, and touch down to 80 beats per minute. And you can see when we get into moderate, we are outside of where we have, blue and we need to inform and get, kind of look at things. That's only if the heart rate's normal. But if we have any tachycardia, any other changes in our fetal heart rate, we're now into yellow and orange and problem, okay? In terms of recurrent lates, we can have mild or less than 15 beats per minute drops below baseline. And I hear this frequently where people say, well, there's subtle lates. Subtle lates are worse. No, subtle lates in the context of late variables and absent variability are a category 3 tracing. But subtle lates in the normal variability tracing with accelerations are actually do not cause fetal harm or any problems, okay? So mild lates, sometimes they're nothing. Sometimes we can watch them. Sometimes we're in the blue if everything else about that fetal heart rate is normal. Everything else is normal. Mild lates are not a thing. But moderate lates, where they're 15 to 44 beat per minute drop, or severe lates are going to be problematic, and we're going to go into a hold, watch, or expeditiously delivery. And then prolonged decelerations are, because they're prolonged, bradycardia, that's bad. How long can a baby keep perfused with an abnormal or slow heart rate? The answer to that question is depends on what the heart rate is. So at 80 beats per minute, we're going to perfuse better than at 40 beats per minute, right? So at 40 beats per minute, if you're seeing a prolonged deceleration that deep, you only have a couple minutes. If the heart rate deceleration is 100 beats per minute, you probably have 8 to 10 minutes because that's not that slow, okay? We have quite a bit of time. Now you can see here, this is moderate variability, minimal variability. As soon as there's minimal variability, pretty much everything's bad, right? The only time we can kind of keep a close eye on things is if we have tachycardia or a normal heart rate with no decelerations. When we get into absent variability, there is simply all of this. Everything is associated with really poor fetal outcomes, acidemia, bad gases, and hypoxic ischemic encephalopathy. Okay, even when we have a normal everything else about the heart rate, it's in the normal range. So this color scheme really points to why absent variability is so problematic. It really correlates the best with acidosis in the fetal unit. I think that sorry, this was supposed to be in color. Somehow it went black and white. Odd. You have this in your handouts. This is the electronic fetal heart rate algorithm from ROLOFF, and it's very similar to the one I just showed you from Dr. Miller, where, category 1, you can have a low threshold for suspicion for evolution or complications or problems. Category 2, you want to do some intervention. That intervention is going to depend on the patient. You want to remember your ABCDs, especially that C, okay? And category 3, we need to absolutely expeditiously deliver the baby. So that's about it, because after now you all lose your attention and zone out and don't get much more out of me talking. So thank you very much for your attention. I look forward to the next couple sessions on hemorrhage and vacuum delivery, operative delivery, and happy to answer any of your questions on record or off record after. Yep. All right. Go to work, go save babies' lives, do a wonderful job, use your NICHD terminology. My residents are going to be impressed by every one of you today. Thanks, guys.